That's true. I have to
I tried it.
Yeah. Just saying.
Maybe that's
Scissors and right now my
my son.
Hello, that's the baby. That's all I really need. You're fine, but that's okay. It really doesn't go for the week.
Yeah, because they're well. So they're sort of.
I'll be here. You can see. Marlon was from Gates and Nancy will be big, but she's coming. So then we went out here to what? Okay, that's it, Marlon and James. And Nancy, we're showing things. But Nancy. I'll make my way up. So then one side. Oh, I don't know. It's now. Well, no, it's not the case. No, we don't have. You got it. Yeah. Whatever you Well, good afternoon. Glad everyone's having a good time. Before I get started, I just wanted to let you know that we do have refreshments in the back of the room. Thank you very much, Jackie, put that all together. Jackie, we really appreciate you doing that. I know that's not part of your usual business. Okay, I'll call the meeting to order. We do have a quorum, so we'll get started. I'd like to introduce our Spanish interpreter and ask you to give us some instructions, please.
Good afternoon, everybody. Pleasure to be here. My name is Pedro Garcia, and I have my partner in the back, and they are invited. And to access the interpret on Zoom, your computer, after the most activate language interpretation mode, click the interpretation icon. It will show the option English and Spanish interpretation available. Then click the language that you would like to hear. It's optional to only hear the interpreted language. Click mute original audio via phone, and your meeting controls tab more at the bottom right in the mobile phone app, and on top right in the tablet app after the host activates language interpretation mode. If the icon is not visible on the screen to make it appear, English and Spanish language interpretation is available. As a reminder, speak slowly, not between sentences, speak clearly, avoid interrupting or multiple people speaking, avoid using metaphors, acronyms, slangs, or idioms. Integrate signals during the meeting. Speak slower, raise your voice, interrupt for clarification, or communicate a concern. Accione al intérprete a través de Zoom o computadora. Después de que el anfitrión active el modo de interpretación del lenguaje, haga clic en el símbolo de interpretación. Mostrará la opción de interpretación disponible en inglés y en español. Después haga clic en el idioma que desea escuchar. Es opcional para escuchar solo el idioma interpretado. Haga clic en la parte que dice Mute Original Audio a través del teléfono. En los controles de la reunión oprima More después de que el anfitrión active el modo de interpretación del lenguaje. Esta opción estará localizada en la parte inferior a la derecha de la aplicación. Si es por su tableta, estará localizada en la parte superior a la derecha de la aplicación. Una vez ahí, haga clic en el lenguaje en Language Interpretation para poder escoger la opción disponible en inglés o en español. Si el símbolo no está visible, toque la pantalla para que aparezca. Interpretación en inglés y en español está disponible. Un recordatorio: hable despacio, pause entre oraciones, hable con claridad. Evite interrumpir o hablar varias personas entre sí. Evite usar metáforas, siglas, doble sentido o modismo. Señales del intérprete durante la junta. Hable despacio, alce la voz, interrumpir para clarificación o para comunicar un problema. Muchas gracias. Thank you so much, everybody.
Thank you. Moving on to introductions, and this is the way we're gonna take roll today, so I'm gonna ask each, because we have a guest, Teresa Comstock from our state organization, so she can get to know you all. I'm gonna ask you all to introduce yourselves and maybe say which district you've been appointed from. And we'll start, Genevieve, can I start with you?
Of course, good afternoon, everybody. Genevieve Flores Haro. I am appointed by Supervisor Matt Levere, District 1, and happy Monday. Thank you.
Hi, Dalia Robkin, as District 4, and Janice Harry.
Good afternoon, Sean Pusey, law enforcement representative.
Good afternoon, Michael Rodriguez, in the Public Defender's Office out of District 5. Thank you.
Hi, I'm Teresa Shell, the Healthcare Agency Director.
Mark Newsom, Office of the County Council. Oops, sorry. Mark Newsom, Office of the County Council.
Good afternoon, Loretta Dennery, Behavioral Health Director.
Cheryl Heitman, I'm chair of the board. And District 1.
Diane Kay, Vice Chair of the Board, and I'm District 2.
Janice Gardner, Chair Emeritus, and I'm from Supervisor Correll's office. District.
Jeff Davis, Supervisor Grills, District 2.
Good afternoon, everyone. Matt Levere, representing the Board of Supervisors.
Good afternoon, I'm Liz Warren, representing Supervisor Lopez in District 5. I am a BCBH client and a consumer advocate and the executive director of the client network.
Good afternoon, CJ Keaton, Secretary, and I'm representing District 2, appointed by former Supervisor Lynn Partners.
Good afternoon, I'm Chris Tejeda, the 4th District, appointed by Supervisor Parvin. Thank you.
Jennifer Morrison, appointee for District 4, James Park.
Mi nombre es Soledad Barragán y represento el Distrito 5.
Thank you. Definitely do have a quorum, and thank you all for making a real effort to be on this important meeting. I know Nancy Borchert is coming, but she said she'll be a little late. Okay. With no just cause, no emergency circumstances, so move on to approval of the agenda, which is an action item.
Chair, I move to approve the agenda.
Second.
Thank you. It's been, did you get that, Jackie? It was
No.
moved by Diane.
Second, Liz Warren.
Thank you. Thank you. Okay, this has to be a roll call. Oh, so CJ,
Thank you. Soledad Vargas.
Present.
Okay, Dr. Under is not, but I will support you here. Game bookings, not. Okay, Jeffrey Allen Davis.
Aye.
Yes, okay, Genevieve Flores Haro. Aye. Janice Gardner. I keep. Myself, I heard Supervisor Rivera,
Yes.
Naomi, Monroe. She's not here.
she's not, and I'm sorry, she did contact me and tell me that she's not gonna be here.
Diane McKay,
Yes.
Jennifer Morrison,
President.
John Percy,
Yes.
Diane Brooks.
Yes.
Michael Rodriguez,
Yes.
Krista Hagan,
Yes.
Liz Warren,
Yes.
and Chair Hyman.
Yes, thank you. That motion passes. Moving on to the minutes from September 16th. And there again, this is an action item. I need a motion and a second. I'll make a motion to approve the minutes. Thank you, Janice.
Second.
Right, there was a tie for second. Diane and.
Diane, time goes to the water, we're a little serious.
There you go. Okay, CJ again.
All right, Soledad. Soledad Vargas,
Yes.
Jeffrey Allen Davis,
Yes.
Genevieve Flores Haro,
Yes.
Janice Gardner,
Yes.
Jane Keaton, yes. Supervisor Rivera,
Yes.
Diane McKay,
Yes.
Jennifer Morrison,
Yes.
John Percy,
Yes.
Diane Brockins,
Yes.
Michael Rodriguez,
Abstain.
Krista Hagan,
Yes.
Liz Warren,
Yes.
Chair Hyman.
Yes. Thank you. Minutes are approved. Moving on to public comments. Seeing any public comments from people in the room? Oh, yes, Karen.
Hi, I just want to make a comment on that.
Oh, you have to come up to the,
Put the mic.
yeah, otherwise the introvert can pick you up.
You take up any time at all in this special occasion, but I just want to put some. And then turn it off on the computer, right?
Yeah.
Already on.
Okay, on the minutes, on the public comments. The last time we met on the 16th of September, I made a comment and it's reflected in the minutes, but it just says Ms. Karen Bates provided a public comment. So, and Pete LaFollette gave one in writing, which is not attached to the minutes that are available here. So I would just like to note that when we have a public comment, I would hope it would be reflected as to what the intent and the content was. I don't want to go through my whole thing again, but I did want to mention that we have no housing for elderly people who have psychotic or psychiatric and physical problems. And that was what I wanted to be reflected in the minutes, so that would be nice next time, I guess. Since the minutes have been approved. Anyway, and Pete's not attached here either, so I don't know what it was that he wrote. Thank you anyway.
Thank you for your comment. Anybody else that's here in the room? I'm not seeing any, and I'm gonna check up there.
We have one.
We have one.
Carol Shelton.
Oh, she's a, I see it now. Carol, yes, I'm glad you're here to make your comments. We got them in writing, but if you can make them, that's great.
The comments were for that specific agenda item. These are general in nature. The comments I'm about to deliver are general in nature. My name is Carol Shelton, and I serve as the Vice President of Autism Society Ventura County, ASVC, and as an active member of its advocacy committee. Our committee regularly reviews agendas from local school boards, city councils, county supervisors, and other committees to identify issues of importance to the disability community. As you move forward with today's deliberations, actions, and goals, I'd like you to remember that there are many unmet needs in the disability community, but few are as urgent, widespread, or impactful as those related to mental health. Our committee is deeply concerned that autistic individuals, both adults and children, are not being sufficiently considered or included in the planning for the Proposition 1 reorganization. Without this inclusion, we fear Ventura County's mental health system may never adequately serve the autistic population. Moreover, we are concerned that Ventura County Health's VCBH Behavioral Health Advisory Board, or BHAB, reorganization will further limit access to care and services due to a lack of appropriate representation for autistic individuals. Families and autistic individuals report that their needs aren't met during a mental health crisis, and they hesitate to call VCBH crisis team because they are frequently denied an assessment. Ventura County is home to a large and growing autistic population. We must offer a continuum of crisis services that meets the needs of every individual who requires support. Autistics experience depression 4 times more than their neurotypical peers. Neurodiversity affirming care is a person-centered approach that too often is overlooked in mental health services, creating significant barriers to care. We frequently hear from adults with autism who are diagnosed with mental health conditions before receiving an autism diagnosis. This is a regular occurrence in our community. Mental health professionals must integrate autism considerations into their diagnostic process, as an undiagnosed or misdiagnosed individual may experience worsened mental health. Time and accurate diagnosis is essential. Unmet mental health needs in autistic children often persist into adulthood, contributing to the high suicide rate amongst autistic adolescents and adults. This is a crisis. It is also why there is a disproportionate number of autistic individuals in our jails and prisons. We respectfully urge you to prioritize the autistic population as you plan for the future of behavioral health services in Ventura County. Only through intentional focus can the needs of this community be adequately addressed. We also ask that you consider Autism Society Ventura County as a key community partner to ensure that autistic voices are heard and represented. We are eager to collaborate. As a reminder, nothing about or for us without us. Thank you for your time and consideration.
Thank you, Carol. Anybody else for public comments? Mary, looks like Mary Hefner.
Yes, hi, good afternoon. My name is Mary Hafner, and I have been an advocate for people who live with the most serious and disabling mental illnesses for over a decade now. I served on the Behavioral Health Advisory Board for 6 years. And I'm an advocate for prompt and effective treatment for people who need it the most. And I know today you're going to be looking at your goals and objectives. And I just wanted to put a word in to this body. As you're charged with looking at all of the mental health facilities in the county. And one of those facilities that actually houses more people with mental illness than all of our acute and subacute facilities combined is our jails. Between April 2023 through March of 2024, Ventura County averaged 99.2% of their population as identified mental health cases. As we all know, mental health cases encompasses all different types of mental health issues, but 99.2% was the highest in the state of California. So there has to be a pretty large percentage of that 99.2% that are people struggling with the most serious mental illnesses. As we know, jail is not the appropriate place. It is not a therapeutic environment for people who need treatment and who need help, the most vulnerable and voiceless. So what I would ask is that this body, the BHAB, take a look at our jails. We've not been able to get very many answers from the sheriff's department, but many people who are struggling are stuck in jail, getting rearrested, and the recidivism rate is high. I don't understand why. We are the highest in the state, 99.2% for that 1 year. So I think it would be something that would be good for this board to take a look at. Thank you.
Thank you, Mary, for your comments. Anybody else? Okay, seeing none, we're gonna move on. Chair announcements, and I'm just going to say real quick, because we have a lot going on today. We did send out a request for a poll, we sent out a poll requesting what you would like to see as your time for the meetings. We've had some discussion about that in the past, whether this is the best time, and people have asked, the board asked that we send out a poll to pull the numbers on what would be their preference. So if you haven't filled it out yet, this is a friendly reminder. We'll probably send it out again if people have misplaced it or don't know where it is. We've gotten about half, I think, have responded. So I'd really like to get more people so we get kind of a better representation. So please respond to it as soon as you can. So hopefully by the next meeting, we will be able to have a discussion about that with the results of the poll. Okay, thank you. Any questions on that? Great, okay. We're moving right along. We are fortunate to have Dr. Cho with us today from HCA, she's director. She's going to be giving us an update on needs assessment.
Great, thank you so much.
Wait, I wasn't on the board. Thank you, Chair Biden. I just wanted to present the board with an update on the needs assessment. Again, I appreciate the board providing that feedback to me as the healthcare agency director to kind of figure out how to move forward. And again, what I heard from the board with respect to feedback was that there was an initial assessment that was done from Evalport that was helpful, but perhaps not as in-depth as the board was hoping to find. And so went back to kind of figure out how we move forward and kind of pick up where we left off with that evaluation and get deeper into the detail that I think the board is looking for. And in that regard, we have looked to HMA. This is a company that we've used before through the healthcare agency for high-level work like this, and have received a draft proposal from HMA specifically looking at the need for quantitative analysis of data. I think there were data that we felt that could be gathered that we didn't perhaps gather the first go around, for instance, data from the jails, utilization data, the type of detail that would give us the ability to see where our service gaps are, as well as develop a predictive tool that will help us in real time do some forecasting. So I'm impressed with what I think HMA is able to offer us in terms of this continued assessment of the needs. And so I would like to take that proposal to the board later this month for approval, at which time we'd be able to further develop what HMA's work with us will be. But I think the draft is very promising and wanted to share that with the board.
Great, thank you. Any questions or comments? Liz?
Yeah. Thank you so much for that. I have a couple of good questions. I may not have been at the meeting where you broached this and discussed this with fellow board members. So if I'm repeating myself or saying something, I apologize. So just very quickly, I'm assuming that you were given the same information, the same direction, the same criteria that we provided for the initial RFP that went out for the needs assessment. That's correct? You have all of that information?
Yes.
Okay. And have you had additional conversations with board members to further that in a smaller group or folks that were involved in the RFP process?
No, not specifically for that purpose. The feedback that I did get was in that session that we had here at the BHAB, and had sort of separate intentional conversations with people in the room to further that. I have had some feedback that has come back to me just through others who've been participating in this process, but not, I don't think that they're suggesting.
Okay, so I might want to throw that suggestion out to you. There's a few of us that, if people haven't approached you, I know that I would love to follow up and chat with you as part of that RFP process. And I'm not familiar with HMA. Who are they?
So they're a health management consulting group that does this type of assessment, has done this type of assessment for behavioral health in the past, and so they bring to the table, and we've worked with them in other aspects too, but they're sort of healthcare experts that understand sort of the need and what we are asking for with respect to the assessment.
Are they California based?
They are throughout the nation. They definitely have a California presence. I don't know that they're solely California based though.
Okay, thank you.
Any other questions or comments? And we do. Hi, Chris.
Thank you. And then, is this gonna involve a whole RFP process, or is this a contract that's already existing with HMA where it'll just be built out, or is there a budget that's like comparable to what EvalCorp went through for that process?
No, so I think this will be a new contract, different budget, so it's not a sort of extension of that same process, no.
So real quickly, but the scope will be the same?
The scope will be, as it was, I believe, the board's original intention to get more of the data that we perhaps didn't see with the evaluations.
Oh, okay, so I guess the concern here, we want to make sure that we don't have a repeat of what happened with the first go around. So, can we get a copy of whatever scope you presented to HMA so we can see exactly what you're asking them to look at? And so that we don't leave anything out and we don't have anything fall through the cracks?
I think we would be probably able to share that with you once it goes through the board for approval. It's not intended to overlap or redo what EvalCorp has already done. So they would have access to EvalCorp's assessment and findings. So the idea is that they would take that and kind of go from there to further the evaluation. So it's not intended to sort of duplicate what was already done.
Absolutely, but I don't think the EvalCorp had covered everything, which we know that that's part of what's going on here. So I appreciate that their findings are the jumping off point for them to use and to design scope of work. I'd be interested to see what that scope of work is that you're giving HMA and what is the attached budget for that?
So the scope of work, to your point, would be basically completing the full assessment, I think, in its original iteration.
Okay.
Right, so it's basically going back and saying, we got part of this, we didn't get everything we wanted, we need you to go back and figure out what we still need to fulfill the original request. The budget is just a little over 400K for this contract.
And do we have any time frame attached to that? Are we looking at a 12-month, 16-month? What's the process?
Initially for 12 months, and then with an option to extend should we need it. But hopefully, we're hoping to get the bulk of what we're looking for within the first year of the contract.
Thank you very much.
Thank you.
Chris?
And just one follow-up real quick too, because I was part of that RFP group too in the beginning, and we spent a lot of hours kind of putting in what we wanted out of it. So I really appreciate it, especially the budget that's going forward with this. The one thing I wanted to stress is, I think a problem that may have ran into is a lot of the different agencies that we wanted to look at capture data in a different format that makes it very hard to compare across different agencies. And the whole intent is to identify those gaps between agencies and handoffs that happen. So I just wanted to throw that out there too.
I really appreciate that. I think the intent is that this group would have the sophistication to be able to do that work that you're saying, to kind of bring it together. To actually look at the data in a way that we can look at it meaningfully, right? So again, I just want to credit those of you who are part of the RFP process. I think that's incredibly important because it tells us what what we're looking for. So this was in no way to sort of go in a different direction. This is to actually stay with the original intent of what you all were trying to find, but find somebody else perhaps with a different skill set to be able to carry that through.
Jennifer?
If I'm off base here, just let me know, but I have a concern, the Prop 1 population that we're looking at now.
to add services to, which we talked about, I think, last time about some of our services kind of being affected by this new population of people. Is that being considered in this needs analysis? Because that's going to add a whole lot of people to the new population of services that are needed.
So if I understood your question correctly, you're asking if with the changes that we'll see with Prop 1, if you feel some people might get left behind in terms of the care that they're getting, and you're hoping that this assessment looks at that? I'm not sure if I don't wanna.
Right, yeah, I want to make sure that we're looking at that added population of people during the needs, in the needs analysis, so that we can make sure we have enough beds and treatment for that.
Absolutely, so an analysis of adequacy of beds is part of that, and so I think, and then again, I certainly can ask specifically for us to look at those types of gaps in care.
Thank you.
Sure.
Okay, anything else? Okay, thank you very much, Dr. Chu, for that update. We appreciate it. Moving along to the director's report, Dr. Henry.
Thank you, Chair Heidman. Good afternoon, everyone. Everything I'm going to talk about today briefly is included in your packet in a lot of detail. Given the amount that we have to cover today, I wanted to make sure we had time, so we put everything out in a pretty extensive written format. But most excited to welcome to our team our new Assistant Behavioral Health Director, Connie Moreno Parada. She is here in the room today. Connie, wave. Very excited that Connie's here. She's been in this field for several decades, working across the state at various counties, large, small, medium, and has tons of experience on both the substance use side and mental health side. Aside from helping me with the day-to-day operations and management, Connie is going to be instrumental in really diving into our clinical operations and really helping us optimize our structures moving forward, especially in light of Proposition 1 changes with all of the other legislative changes on the LPS side, and with our overhaul due to Medi-Cal reform and Kelly. So she's an expert at service line integration and administrative functioning. So we're very excited to have her here leading the department with me as we move forward. Which kind of brings us to our next large update. So what we did is we went ahead and included from the director's message that I sent out to our staff a couple of weeks back on our department restructure, which I have mentioned broadly to this group as we've talked about the various initiatives in the last 6 months and what that would do organizationally and how we would have to restructure ourselves organizationally to meet the demands of these new state and federal changes. And so I said, why not just share the message that went out to staff so everybody knows what's been communicated as far as the restructure as a result of all of the things listed here in your report today. So the main takeaways as far as what's changing is we have to completely shift our organizational structure. We are looking at integrating both mental health and substance use. We are looking at the interface of our forensic services and what it means down the line for primary care integration. And so just making sure that we're set up in the most appropriate way to maximize funding and making sure that we can maximize all of the things that we're being asked to do, given that we're not going to have a ton of resources put into that from the state as far as bodies or money, right? So the takeaways are, and if you have more questions about what all lives under these divisions, please feel free to check out our org chart on the website, which has been updated. So shifting into our managed care world, we have our managed care operations division, which is being led, this is all effective now, by Karen Lee. Our forensics justice and reentry services division, Dr. John Schipper. Our outpatient clinical operations, and that includes integrating mental health, substance use, and youth and family on the adult and mental health and youth and family mental health and substance use services under Rainer West. And then our critical care and navigation services under Sarah Sanchez. That includes our RISE team, our crisis team, our outreach engagement teams. And we've shifted a number of programs and functions around. So I would encourage you to check out our org chart, which we update regularly. It's huge at this point, hard to print out, but please go on the website and look, and you'll see what different programs and functions, operational functions live within each division. We've also restructured as part of our managed care applications, our administrative integration, our financing, and so under our CFO, Narcy Egan, kind of really overhauling our fiscal and billing. That's how they were known, into a true finance and administrative services branch. To really, again, looking at maximizing our revenue recovery, making sure that we're drawing down funds and really being mindful and purposeful with the limited resources that we have, given the various competing demands that we have to navigate through in the next several years. So there's more detail in the director's update as far as, why this matters, what it means, all of the communications and the next steps that will happen with staff. Obviously, this is probably the largest change that's happened as far as structurally in the department in quite some time. And so there's been a lot of thought and effort put into messaging with staff at the executive level, and then all the way down from our management team into our service line level. And so Connie and I will be doing lots of listening sessions with our staff, our line staff, our management teams, to help do this transition. This is not a rip the Band-Aid off situation. This is gonna be a slow, transformative transformation. As we've talked about in this meeting, we're basically being asked to overhaul a 50, 60-year-old treatment system in like under 5 years, really like a couple years. So when you look at it that way, there's a lot to do, but we also want to be purposeful and thoughtful, especially because we have actual human beings and lives who work for us who, need to make sure that they understand and have a say in how these changes roll out. So we're very much looking forward to that next steps. And then following that, in your director's update, you'll see the disengaged service line development, again, going into more of the why this is all happening and putting some words and visuals as to these state changes coming down and how, as a department, we have to be responsive to that and support our organization to help make recommendations to our CEO and board on some of the decisions that will have to be made moving down, and kind of delineating the differences between service lines and programs and then actual services, looking at agencies versus practitioners and then providers, and what all that means and how all of the dollars and cents, help. Because at the end of the day, we're trying to maximize to give high quality care for our populations that we're responsible for, while also helping our partners lift up their pieces of the pie, because the mental health system, the behavioral health system is a very large system. We are a piece of it, and we all have to make sure we do our part for the greater good. So some of that is all covered in here. We will talk more in the next, coming months about what these changes mean and how they impact some of the new programs and services that are kicking off later on this year, including CARE Act. We talked about a lot of that in the presentation we did back in September with Proposition 1, administrative integration, and BH Connect. And so this will help us down the line. So with that, we have different regular updates throughout, kind of broken out by division, the newly structured divisions, but I'm happy to take any questions right now. Liz?
Yeah, thank you for this extraordinarily thorough, and I really appreciate you sharing your internal communications. That's tremendous transparency, and I really appreciate that because it shows me how you're communicating with staff. A couple of quick things, and I may have missed them, but it says that you're going to be breaking it up no longer by age, but you're going to be looking at it integrated across these different divisions. So youth and family and adults are going to be integrated. That's correct. So will older adults be in with adults then?
So yes and no. So obviously there are some very specific things that will need to be maintained, right? So our older adults population are very specific. Our perinatal services are very specific. So when we say integrated for now, because this will change in time, for now, we're saying at the management level, at the executive management level, and then as we move into an integrated management team level, folks are going to be responsible for more than just their little area, right? Or their large area, but really looking at it from a system integrated process. We are being asked to make a lot of changes while the policies and protocols are still being written at the state level. So even though this is the direction that we're moving in, we know this is where the state wants us to go, we're still bound by the constraints that we have as far as how we're financed currently, how we're audited currently, and we're still kind of living in two separate systems. But we don't have the option to wait until the state has it together before we start the shift, right?
Right.
Especially because we know this is gonna take years to integrate, especially when we start getting at the service line level. But if you look at the philosophy behind the Calling no wrong door policy, in theory, someone should walk into any single clinic and get any kind of service that they need, whether that's for a youth, an adult, an older adult, a perinatal, whatever. That's the, you know, the mindset behind that. The reality is, we still have to operationalize that as a system. So this is a step in that direction. And we're not gonna get there overnight, but this is where we're gonna start.
Right, thank you for that. And you said it's a slow transition. So do you have some kind of workable timeline? What are you working with?
So we're working on that. So as far as it's gonna be a transition, it's more of a philosophical, it's gonna take time, right? Again, so we're gonna start shifting, integrating where we can as far as, you know, we have alcohol and drug treatment counselors that can be better integrated into the youth and family clinics, into the adult clinics, and vice versa, where we've already started to put more therapists and clinicians into the SUV system. That started back in 2018 during DMCODS. So there's a lot of integration at the service line level that can continue to grow. But what we recognize is that that's all great, but if we can't align ourselves at the management level, starting at the executive level and at the management level, it makes it really challenging for staff at the direct service level to know where to put their energies because it's not clearly delineated. That is what we're saying. The state, well-intentioned, has not really given anyone any kind of like playbook on how to do that. So that's what we're looking to do and create, because we have to make it work for Ventura County. That's what Connie has had a lot of experience doing in other places. So we can take a look at our own structure to figure out what makes the most sense. And then by the time the state catches up and, you know, has the integrated billing mechanisms and has the integrated clinical tools, we'll be ready as far as our organizational structure. And they're working on that. So that is the first piece with administrative integration that goes live for us in January, so very soon, where we'll be under a single contract with DHCS. So up until this point, we've had two contracts, one for the mental health plan, one for the DMCODS plan, with different requirements, different timeline, different reimbursement structures, all of that. So the state is moving towards aligning that. Everyone will be under that model by 2027, but we are an early adopter county, so we're going live in January. And so we will be the first to try out this new integrated contract, and then we'll go from there.
Great. So, real quick, the spa division that we used to have is being broken up, or now that's the new finance and admin?
No, so spot's still there, so strategy planning administrative on that piece is still there.
Okay.
And that will report up through our chief of staff, Chantrice DeVera, to the director's office.
Okay.
So that's one piece, but on the finance side, what we recognize is that we were lacking the administrative pieces behind financial services management. So that's what's being retooled on the old fiscal and billing side.
Great. One last question for you. Your whole listening sessions, which is fantastic. Could you extend courtesy and perhaps have a listening session for a few of us that really want to get, when you're ready? I'm not ready yet, because in order for me, in other words, as a consumer advocate, when I'm helping clients and peers navigate the department, if I'm making referrals, if I need to know where to go, I would like to get a real deep down briefing, because but you have a working knowledge that a lot of us have, that's been of how the department is based on years. It's gonna be, I'm gonna need to know as much as possible in order to be effective in my job.
So there's two types. So the listening sessions that we were referring to were specifically for staff who will be going out claims, but we are also working on public listening sessions, which I've talked about before, that I will be doing. Oh, we're trying to get them in the fall, but you know, schedules are tight, the holidays are happening. So I will be doing a couple of things with some of our law enforcement. I'm partnering with some of their, you know, events, so I will be there to field questions or just listen. But that is another thing on my list of things to do.
Sure.
In early 25, and we will be doing that also for Proposition 1, because we have to start that 18-month transition in January. So that is on our list of things to do next year.
Thanks very much.
No problem.
Anybody else? Interesting. James, good. Good. Could you, expound a little bit on the. I don't know. And could you expand a little bit on, the, integration of the, substance use? Are they trainees that'll be coming in, or they, or how, what kind of, you said that you had some sus people that would be coming into the clinics that have expertise, or are they just, are they licensed, are they?
Sure, so we already have certified alcohol and drug treatment specialists who are already embedded in some mental health clinics. So what we're doing is we'll be expanding upon that model, really ensuring that folks are working at the top of their licensure, at the top of their scope to provide those services, even if they're delivered in a mental health setting. That historically has been challenging because of billing purposes and because of reimbursement purposes, to where it's been hard to do that. But now that things are changing, we're gonna be able to ensure the same way that clinician who might be a licensed practitioner of healing arts, LPHA, can deliver therapeutic sessions in a substance use setting, the reverse can happen where our ADTS can provide information and counseling sessions, medications for addiction treatment, all of that, even in the mental health. So we are already doing a lot of that, but this is really having a more formal, structured approach so that we can have consistency throughout the system, right? So that depending, you don't have to, doesn't matter which clinic you go to, you'll get the same menu of options and they'll be applied in the same way, as opposed to some places are doing it one way and other places doing it the other way. And so that's what we're looking at. We're also looking at down the line as we're moving towards implementing SB 43 and the changes with the LPS, looking at integrated programming at a residential level as we move forward with that, because we know that SB 43 allows for a new SUD population. And so those are more of our acute settings, looking at MHRC level, looking at ICU level, looking at health level. But again, we have to wait for the regulations to catch up, because even though the legislation was signed last year, we're still not technically able to serve folks with an SUD and like an MHRC, an SUD only. Right, so again, it's some of it's cart before the horse, but if we don't get ourselves structured organizationally, when that legislation finally gets changed or that policy update does allow for that, we'll be ready to go and ensure that our staff are trained appropriately to be able to handle these populations.
Thank you so much for all of this clarification. It's really very, very helpful. Really appreciate it. Welcome. Michael.
Good afternoon, thank you for your report. I had a question in regards to CARE Act, because I'm looking at these 4 units that you described in your report, and working with forensics justice and reentry services. It seems like CARE is going to straddle a few of these. And so how is that going to work as far as services being seamless, integrated, et cetera?
Yes, thank you for that question. It's a great question because that is the reality, right? All of the services moving forward are likely going to straddle across every single service line and every single division. And so that is something that we are actively working at the executive team level as far as what does that look like? What does it look like to work in a true integrated team and not in silos? And that's what we've always done historically. We as a system, including the department. And so we have been doing a lot of leadership development. We've had consultants come meet specifically with our executive team recently in the last couple of weeks to really sit down and look at what does that mean when I say it like the only way I knew how to say it was everybody's all up in everybody's stuff, right? And that's just the world we live in now. And you don't have a little kingdom or queendom anymore. What does that mean when we are gonna hold ourselves accountable because our people are gonna straddle the line? And so that's also what we're building out in time, because the reality is all of our people coming in have something that has to do with everything, whether it's forensics, a mental health condition, a substance use condition, they might also be unhoused, they may also be pregnant. So we're gonna hit every single one of these divisions. How are we ensuring coordination and synergy? And how are we sharing information from like our real-time clinical, actual information? And then how at the administrative level are we ensuring seamless, coverage and maximizing our billing and revenue? So all of those things at the same time. So that is an active conversation and that is what we're actively building out. And that's something that is also gonna take some time because that's a complete culture shift. And this, again, while we're doing it and, there are other people in different places across the state, this is the model that most places are going. You can take a look at anyone's posting across the state as far as behavioral health departments. They're integrating their outpatient clinical operations, they're integrating all of their service delivery. And this is it might look a little different, they might call it something else, but this is pretty much the model that you'll see across the state now.
Thank you.
Do we have an update on the MHRC?
It's moving, I mean, there's really not, other than we're continuing to go through the process of, securing land use surveys and making sure the roads are to where they need to be, we're just kind of in the trenches of planning, so. Not much more than that. It's a lot, but until they start, building, I know it's hard, but there is a lot of work happening at the planning level.
Do we know the time frame between now and when that actual work will start?
I don't have that, but I can ask for that from our capital projects folks, because again, all of the actual infrastructure building lives outside of the department, but I can request updates for that and bring it back.
That'd be great, thank you.
Anybody else? Yeah, Chris?
Sorry, you just touched on something really, really important, is with all the different agencies that you're talking about, everybody's sharing the same essentially clients that you're serving. Has there been any state guidance or have you found a solution locally as far as sharing PHI and how you guys are monitoring all that? Because I know that there's a sticky point, like everybody has different systems and it's just very, very difficult problem to solve. So.
That's a great question. Thank you for that, Chris. So there has been a lot of work done at the state level as far as helping expedite that and keeping in line the federal guidelines that we have to work with HIPAA and 42 CFR. There have been some changes to both of those recently that will allow for more efficient and seamless data sharing. So my counsel's right here. She's been spending a lot of time working with other agencies and their councils to ensure that we have a release of information, consent, that we can share information back and forth. I say we are much closer than we've ever been in time because now there's new state and CMS guidelines as far as information sharing that everyone's held to. And so even in the past where maybe our department was willing to share information, but other people didn't necessarily want to take it because they didn't want to assume that risk. Now that the rules are changing, it's going to be a lot easier to facilitate because at the end of the day, this is all great on paper, but if no one's sharing information, then it's not really helpful. So we are moving in the right direction there. There are, again, a lot of policies being updated as the federal and state guidelines have changed with information sharing that multiple agencies will be held to, especially in healthcare.
Anybody else? Good questions. Really good. Well, thank you so much for this report. I think more to come, obviously, this will be an ongoing, but a lot for the department to be dealing with, and we appreciate being kept in the loop on this and letting us know what's going on, so we can continue to ask great questions. Thank you. Okay, so today we have a special presentation and a project for all of us to participate in. With us today, we have from our California Association of Local Behavioral and Health Boards and Commissions, Teresa Comstock, who is the executive director. Welcome, Teresa. Thank you for coming down from Sacramento or Napa. You actually live in Napa, right?
I live in Napa, yes.
Yes. Thank you.
Glad to be here.
For coming down and helping us. She has provided each of you with best practices notebook. If you didn't get one, we'll get one to you. So it's good to have a reference on all kinds of things. I think you're gonna be referring to a lot of it. In the presentation, we appreciate you also bringing those to us. That's gonna be very, very helpful. Um, and we are going to be, Diane's gonna be our scribe, so she will be going up there when we get to that part of the presentation. So I'm gonna turn it over to you, I think.
Great, thank you. Yeah, I'm really pleased to be here. Thanks for inviting me. Again, I'm Teresa Comstock and I'm so thankful for the work that you do on behalf of Cal BHBC. We appreciate everybody that serves on your board, as well as the staff members that help support the board and the public that helps inform the board and all the providers. It's a heavy lift for an advisory board, all of the requirements that you have. And really appreciate that you're all willing to roll up your sleeves and come to the table and inform the system in terms of, you know, you're experts in your own experience, and that really needs to inform the system and improve behavioral wellness in your community. So thank you all. So as Cheryl said, I'm gonna do some talking before we open it up to discussion around priorities. Because I see this as an opportunity, at least once a year for boards and commissions when they're setting their priorities to review what their requirements are, since there are so many. And what you do is so important because the behavioral health director, they sign off on agreements with the state, agreements with the federal agencies, and then also, you know, they're administering local agreements as well. And they need you in place in order to do that legally. They need you to be meeting and listening to them as they review any of the new initiatives or ongoing initiatives. And in the behavioral health field right now, things are just exploding. There's just so many changes. We're learning a lot, but we have a lot of work to do in order to implement successful programs and services. So inside of your packet is this behavioral health board goal setting presentation that I'll go through. Thanks for putting it on the screen. All right, so we'll go to the next slide. We'll review the duties. So the state has law in place for your duties. And what I'm going to review is the duties that are updated now, and it's effective January 1st. The duties have changed just slightly. You're not just over mental health. You are now over alcohol and drug services. So you're required to be a behavioral health advisory board now. And then we'll go into identifying priority areas. And just so that you're thinking about priorities as we go along, I wanted to give you an idea of what the process will be later. For the board members, we have these stickers that we'll be writing down some of your ideas for priority lists, priority areas, and then allow you to put 1, 2, 3 top priority, second top, and then third top priority stickers next to those items. And we also have stickers for the public if they're interested in putting stickers on, and that will be in red. All right, next slide. All right, so the first duty is to review and evaluate the community's public behavioral health needs, services, facilities, and special problems in any facility within the county or jurisdiction where mental health or substance use disorder evaluations or services are being provided. And there's more in code, but this is directly out of state law. So reviewing and evaluating the public system. We have some ideas for tools to use when you do that. And the best practices document is something that you can refer to also with these tools. They're embedded within that. The first one, something I'm sure that you probably do, speakers. We suggest doing panels of speakers. in order to bring different sectors of the community together over a topic. So say you were looking into school-based services, you might have folks from nonprofits that serve children and youth in the schools. You might have staff in the schools, County Office of Education agency staff, and behavioral health services staff that serve children and youth. And then also advocacy organizations, NAMI or United Parents, groups that focus on children and youth. And community forums are another way to review and evaluate. So basically, you know, you are a public board, so you need to have agendized meetings that are posted in advance and they need to be open to the public. So you could call it a community forum though, just to get the community's interest and put it out there on flyers, things like that, on what topic it is. So you're bringing more and more people that are interested in that topic to the table. Let's go to number 2, liaisons to commissions and committees. So encourage you, if you've identified priority areas that intersect with other commissions in this county, to have one of your members regularly attend their meetings. Share, if you've made recommendations around an item, share your board's recommendations, but also bring back information from those committees. Number 3 is site visits, and we have suggested site visit observation form and procedures in our best practices document. And then ad hoc committees. On our website, it's calbhbc.org, we have over 30 areas for issues that you could be looking at. You know, there's so many issues related to behavioral health, so many sectors that intersect. So ad hoc committees can be a way to really hone in on something and do some research meetings together outside of your board meetings. So it needs to be less than a quorum of your members. Usually, you know, it's usually 1 or 2 members that will really roll up their sleeves and work on the topic together. And maybe they can help draft a recommendation around that topic after they've done some research meetings or looking at documents, that sort of thing. And then performance outcome data, which it looks like it will be more standardized over the next few years. Proposition 1 restated what was already in law, was that the Department of Healthcare Services and some other state entities were supposed to standardize performance measures. So they're working on that now. And so hopefully we'll see you know, specific measures that every single county will be reporting on. But right now we do have some of that information from your county. You know, they put it into different reports related to some of the grants that they have from hospitalization rates, also rehospitalization, Medi-Cal, that's in a report, and then the Mental Health Services Act, there's some performance measures that the county tracks. All right, let's go to the next slide. All right, review any county agreement entered into pursuant to Section 5650. You shall make recommendations to the governing body, which is the governing body is the Board of Supervisors here, regarding concerns identified within these agreements. But keep in mind, the slide before said you're also advisory to the behavioral health director, so it's both. Ways to review would be, of course, staff presentations and reports. There's information that you can review regarding the agreements that the county has. There's a report called Annual External Quality Review, EQRO, that provides recommendations. So annually, the county gets an audit, and there are recommendations that are made. There are performance improvement plans that the county puts together. And you can go, take a look at those, I would, specifically look at the recommendations, ask for staff presentations on that. But look at it yourselves also. I think it's a lot of times, we want to highlight areas that we've been able to fix immediately. But you need to know overall, what are the state's recommendations. Behavioral Health Services Act. Reviewing that is no small task. It's a huge report. But it's good to review that. You in every monthly meeting that you have, you're listening to the public, you're listening to staff and contractors and hopefully you're getting some idea of areas that you would want to make recommendations on in this area. And we'll talk about that in your goals as well. And then SAMHSA, which is Substance and Mental Health Services Administration grants, they have a lot of areas where they do track data. And in all these categories, Medi-Cal, BHSA, and SAMHSA, the county is doing a lot both within their internal organization as well as contractors with contracts that tap into this funding. And then RFPs and RFAs. So if it's a major new contract, so RFP means request for proposal. Our RFA is request for application. So reviewing contract proposals is within your purview. So you could have maybe, less than a quorum, but I would suggest 1 or 2 people that are interested, invited by the staff to participate in reviewing applications and being on the panel to interview potential contractors. And then with site visits, that's another opportunity to look at a contract, and specifically looking at deliverables is helpful. So you get an idea of what is required in the contract with the county. All right, next slide. All right, so it advises the Board of Supervisors and the local behavioral health director regarding any aspect of the local behavioral health program. So it's Board of Supervisors and behavioral health director. Oftentimes, you're going to be wanting to make your recommendations to the staff here because especially if it's something that's in the control of the staff to change. And then also in your annual reports, put those recommendations there for the Board of Supervisors to see. But sometimes it's going to be areas that intersect with the behavioral health agency. So it's outside agencies that the Board of Supervisors, maybe you might want them to be aware of your recommendations so that they can increase collaboration between different agencies. Or maybe it's a specific community issue that you see that's affecting behavioral health. For instance, in San Francisco, there were a lot of suicides on, over the bridges, the Bay Bridge, Golden Gate Bridge. So it took a few years, several years, but the commission there made a recommendation for some netting to prevent people from falling. Where are we? Okay, so when you're gonna make a recommendation, we break it down into 3 things. First, identify. Second, research, and then third, advise. So of course, you need to identify, listen to public comment, your board members, you have your own interests that you can bring forward as well. Look at the performance outcome data. Not only do you want to know if people have access to services, but that's not enough. If you could be accessing services, but not getting good services. So looking at what are the outcomes when people access services. Getting presentations from staff. We put in here patients' rights advocates, because they can visit any of the facilities in the county, and they're a good source of information. And then contractors as well. And even when you're doing your site visits, we recommend that you ask contractors, are there barriers and challenges that you would like to see, changed in the county? All right, and then research, ad hocs. Which in the best practices document, we have some structure to help you with that. So that you stay within the Brown Act, but are still able to use this tool, which does not require Brown Act meetings. So they're short-term work groups, usually a small number of your members, 2 or 3 usually, and it's time limited, so it's just a short-term meeting. It could be something, you're open to researching, you can invite who you want to your meetings, you can call each other on the phone, you can email each other, you can discuss it by teleconference, however you want, and you don't have to post those meetings. And then the chair should be meeting regularly with the behavioral health director, so they should be, in conversation in a couple ways. One would be understanding from the behavioral health director's perspective, what priority areas or challenges or barriers they'd like to have recommendations from the board on. And then on the other side is the chair could be representing the board on the priority areas that they've identified. And if you've made some recommendations to be, having ongoing conversations around that too. All right, and then you advise. So a lot of work goes into it before you advise, and we want you to do it as a group together when you advise, not just have one-offs telling staff what to do. We want you to work together as a board, as a team. And then when you do that, it's recognized as it's a tool of the board. It's a recommendation of the board when you've gone through a process. So whoever worked on the recommendations, they drafted. Actually, we would suggest that it goes to the executive committee. They review that and determine, is this something that we want the board to vote on? And fine tune it maybe, and then put it on a board agenda. And the board can vote on the recommendation. All right, next slide. Okay, so this is the one area that you actually approve something. Everything else is review and advise. This one actually says review and approve. It's review and approve the procedures. Just lost the top there. Okay. Review and approve the procedures used to ensure citizen and professional involvement in all stages of the planning process. So the planning process is extremely robust, especially now after Proposition 1 passed. Within the best practices document, there are 2 pages that summarize the requirements that the staff has for behavioral health services integrated plans. So there's a 3-year plan that needs to be developed, and the community needs to be part of that planning process throughout the planning process. And then, with other major plans, like cultural plans, that sort of thing, there's requirements as well. So wherever the planning is taking place, we need to ensure that the citizen and professional involvement is also there. So board and commission meetings, that's an ideal place for the public to come. So publicize meetings and topics, encourage public comment, create accessible locations and times. And then tools, and actually I should talk about accessible locations and times, especially now that you have the requirement to have a member that's 25 years of age or younger. You need to be very careful to make sure that you have that person. It's a requirement of your membership. And a lot of people that are that young, they cannot meet at 1 o'clock. That's sometimes they're in school. So you might want to reflect on that and decide, and, you may actually, create a new teleconference, physical location in your county, so you have dual, locations for your meeting, one at a high school, one here. And that would increase the youth involvement as well. All right, so. We talked about these tools already, but specific to making sure that the community is involved in planning. You can do staff presentations, ask for presentations specifically on the planning process, ask for updates as the year goes around. You are a diverse board reflecting your community, so hopefully you can provide some advice on how to get into unserved and underserved communities, or you have identified areas of the county that you want to make recommendations to the staff, that we really need to engage these communities if we're really going to make a difference. Staff reports and updates. Okay, we talked about that. Attend public events. So the behavioral health board, behavioral health agency is probably putting together a lot of events during the year, in order to ensure that the integrated plan is informed by the community. So we have members go to that. It's fine for you to go. It can be a quorum of you. If there's that much interest for you all to go, just sit in different places and don't be part of the discussion. We don't want you to go outside the Brown Act, but we want you to be listening to the community. Yeah, Michael?
I wanted to go back to your discussion on the example you gave as far as perhaps having a site at a high school for the
Yeah.
board meeting. And so to comply with the Brown Act, we can have an alternative meeting site that's open to the public, which would comply with the in-person requirement as opposed to me being in my office and sitting in. Is my understanding that correctly?
Right, yeah, the Brown Act allows the teleconferencing as long as the agenda, it reflects all the addresses where the physical location is. So, yeah,
Okay.
it's fine. Yeah, you would still need to do roll call votes, but yeah, it works.
Lisa, yeah, quick question about attending public events. I'm wondering how we would find out about a lot of the events, other than, a lot of times, I know for myself, the events, I find out about after they've happened. So I don't know if there's a way of finding out prior, if it would be through the department or, because I'm not on the press releases or things like that. That's probably after the fact too.
All right, yeah, that would be something to be asking when you're asking for those presentations on the planning process. Maybe you could be asking for anything that's open to the public, ask for the schedule, what they have planned.
Sure, I mean, we regularly provide during like the CPP period of like where we're gonna be when we have offsite town halls and different parts of the county. Yeah.
I thought, okay, I'm sorry, yeah, I'm aware of those. I was just talking about other events that are happening. Like there's something at City Hall tomorrow.
Oh, like outside of the department.
Whatever, yeah, it just says public events, that would be mental health or substance use related.
Right, yeah, I'm really focused on, the interaction between the agency on this, because they're the ones that have the heavy lift on. She said CPP, which is Community Program Planning. Actually, they've taken that term out of the Behavioral Health Services Act, and it's just called a 3-year integrated planning process. So I don't know what our new acronym is, but. Right, so, I mean, if you're gonna hit, so within this new requirement, there's 29 categories of stakeholders that have to be. Part of the process, so you will see a lot of planning in these plans and hopefully, that will be enough meetings for you to go to, but.
Dr. Jenner's you've been great about letting us know about like CPP or whatever integrated plan meetings, and several of us have attended quite a few of those.
Okay.
Okay, thank you.
Yeah. Sure, and then, when we talk about planning process, especially for unserved and underserved groups, that might not be a public process. You might not be invited. Because there might not be a way to engage people publicly that are not really interested in coming to a public meeting. It may be outside of their schedule, outside of their work schedule, outside of their family schedule, whatever. But I think that we need to look at innovative ways to reach people. And that might be, the staff might just go to a community center where, we've identified a population that should be part of the process that doesn't normally come to one of the county meetings. And the staff might run a listening session there. Okay, let's see, where are we at? All right, so liaisons, again, having liaisons to committees can be helpful. The county likely has a cultural committee, and that might be like a medical requirement, or I'm not sure if every county has one, but most counties have a cultural committee, and there's a quality improvement committee. So going to those committees, if you have one or two of your members that can go to the agency committees and sit in on those. Often those are monthly meetings, and you can look at data and listen to people and learn more about barriers and challenges, but also learn about successes. And then review the adopted. So we put in italics adopted Behavioral Health Services Act plans and updates. The adopted plan is the one that you should be looking at, not the draft plan. So when the county has put together the draft plan, and then they say, okay, we have a 30-day public comment period, and then at your board meeting, you're gonna have that public hearing on the Behavioral Health Services Act integrated plan. That's the time for the hearing, and the plan itself that's not the time for your board to be making changes to it, because it's already kind of getting finalized and on its way to the state. But the rest of the year, so after it's adopted by the Board of Supervisors, then you would be looking at that for your recommendation. So it's the adopted plan. Okay, and within that, looking for ways to ensure that the plans address the community. So what you've heard, hopefully you're looking at that adopted plan thinking, is this what we've heard? What kind of recommendations should we be making to staff? All right, so we have some resources here on the best practices in the best practices handbook, detailing all those 29 different stakeholder groups and what the staff's role is, what they're required to do. And then also what I just reviewed in terms of you need to be looking at the adopted plan. And then cultural requirements. So there are requirements also for the county, and that's detailed on page 11 of the best practices handbook. All right, next slide. Annual report every year. So you should be doing an annual report, and we underline needs and performance. So this is straight out of law. That's what they want you to be reporting on to the Board of Supervisors, on the needs and performance of the county's behavioral health system. So it's your opportunity to advise. We have some suggestions in our best practices as well on that. Next slide. And then the behavioral health director, if that becomes vacant, then you are supposed to be part of that process. Next slide. You should be reviewing and commenting on the county's performance outcome data. And then communicating the findings to the Behavioral Health Planning Council. That's not my group, although we kind of help with getting the most current information to them so they can send these data notebook surveys to you all. So once a year, the Behavioral Health Planning Council comes up with questions that they would like answered. Our organization, CalBHBC, we have actually been advocating to them for several years to focus more on performance outcome data because we haven't seen many questions around that. So hopefully we'll see more of that. I think within the current data notebook, the last page of questions are around what you would like to see for performance outcome data. So that's a step in the right direction. All right, next slide. Yeah, this slide, we have just a listing of the performance outcome data that's most commonly reported in the counties, and then we put it on our website. So every county has a web page on our site, and we've identified what we could find in the most recent reports on our website. And so areas in children and youth, usually it's related to self-reported wellness, family reported wellness, to teachers, what they report on behavioral wellness, and then attendance and grades sometimes. Criminal justice, usually the measures are around reducing arrests and reducing incarcerations for people that have been involved in the criminal justice system. And then employment, that's measures around competitive employment or education related to vocation for people that are in the behavioral health, that are being served by the behavioral health agency. Hospitalization, that usually shows like psychiatric hospitalization or rehospitalization. Some of the counties are reporting on visits to the emergency rooms. And what else? That's an area where sometimes we'll show also the crisis services visits. And then housing. There's information on reducing homelessness. All right, next slide. And then there's more duties, if you get them. Don't know that your board of supervisors here is added anymore at this point. I don't think so. There was a county a while back that was told that they should be also advising regarding the public guardian's office. But that's not usual. I mean, we don't see that very often. And then you should be assessing the impact of realignment. When you hear information related to how the county is spending their money, realignment, usually I think it has a smaller percentage than Medi-Cal and Behavioral Health Services Act, but it's a significant percentage of funding. So realignment means just times in 1991 and in 2011, where the state took what their responsibility was and they said, no, we're going to have the counties be responsible, and had identified funding streams for that. All right, so next slide. All right, so we have one just on the Behavioral Health Services Act. Also, just to make sure you understand your role and that duty that I already reviewed. You should be making sure that the community is involved in the planning process. That's number one. And then number two, you review and advise. And there is a process for making sure that the agency will respond to you as a board when you make a recommendation. So if you vote on a recommendation during a meeting where you have a quorum, and you have voted to support that recommendation, then the agency, if it's a Behavioral Health Services Act recommendation, the agency either needs to implement that in their next integrated plan, or they need to explain why they did not to the Department of Healthcare Services for California and to your Board of Supervisors. And then the third here, of course, is you conduct the Behavioral Health Services Act public hearings. So it's an important role that you exist in order to get this funding. All right, next slide. Okay, so identify priority areas. Inside of your handbooks, we have, I think about 11 different issue briefs that Cal BHAB has put together over the years. It's in the sleeve on the left side. We just wanted to give you an example of some of the things. Sometimes these come out of counties where we'll get issue briefs out of counties after they've had an ad hoc committee and they've looked locally, you know, at an issue and made some recommendations or identified barriers and challenges, or you've identified successful programs. So some of our issue briefs reflect that. Sometimes we'll take an issue brief, we'll just look at major reports that we've seen maybe from other states, other counties, or California itself, or federal reports, and just hone in on, you know, those types of issues like challenges, barriers, successes. Sometimes we'll even say what questions you should be asking your staff around these issues. So I just wanted you to, you know, just kind of see that information here, just to reflect on what is an issue as you just decide to define what your top priority areas are to look at. And I know a lot of you you're really interested in seeing, you know, some of the interactions with these major initiatives that the state is requiring this agency to implement. And I think, you know, you can probably be assured that they're going to continue to report on those major things like Proposition 1 and Behavioral Services Act and the CARE Act, that sort of thing. All right, so Diane, you want to?
Want to ask if there's any questions yet on what you just presented, which is great. Thank you.
Good, thank you. Yeah, any questions before we start this discussion on priorities? Yeah.
Yeah, I just had a couple of questions. For the performance link that you mentioned too, I know there seems to be an issue with the billing reconciliation cycle of things, right? So it's typically like 2 to 3 years back that we see those reports. So what do other counties do to be able to get good data as soon as possible? Where we always have that problem because data is always behind current demand, you know, right? Because I just clicked the link for the performance and the reports are for 2020, 2021, that kind of, there's blatant.
Right, yeah. Some of the counties do have more, and maybe this county has more current data. We'll take a look for Ventura, because we have seen 2022, 2023 data. And then also the Quality Improvement Committee here, they're always talking about the data. So that's another way to be connecting with them and looking at their reports.
through the EQR reports?
The Quality Improvement Committee is a committee of the agency.
So we have a QIC committee, Liz sits on our committee as well. But if you can attend that meeting, if you want, we do regular data updates to that meeting, so.
Thank you. Appreciate it.
And I think with the requirements with the Behavioral Health Services Act, maybe that might actually, they've got different deadlines now also, and they will be laying out what the requirements are for data, so hopefully that'll help also. Any other questions or comments? Okay. All right, so shall we start with does somebody want to volunteer a priority area that they're interested in? Okay, Liz.
Yeah, so before we get into that specifically, I just want to circle back because you've covered some of it. You covered some of it in your presentation. Thank you for that, Teresa. But there are a lot of existing strategic plans within the county. There are BCBH plans, county plans, there are HCA plans, there are MHSA 3-year plans, there are 6-year plans, there are plans with revisions. So what I want to make sure, I mean, I got them, and they're available on the website. The last one was the 3-year plan for 23-26 with a mid-year adjustment, and we got the $30 million we talked about the MHRC. And so I don't want to do anything that's going to duplicate effort, but I want to do things here that are going to complement priorities that have already been identified through the community planning process, which is now evidently the integrated community planning process. And so that we can identify based on recommendations from the EQRO, we have those recommendations, the strategic plan priorities, we've got those, the MHSA plan priorities, we've got those. Why don't we take a look at some of those existing areas? We also had identified areas we were interested in finding out more data on in our countywide needs assessment, which didn't go exactly the way we had planned. So we're still kind of behind the 8 ball, waiting to hear more about gaps in services and areas that need to be integrated and how the county is interacting with all the different departments and how within the realm of behavioral health and how they all work, if there's a synergy there or not. And so I'm just going to be the cautionary person here saying, we can get ambitious with some of these things, but if we're not kind of in line a bit with what's already been identified, with some of the things that have been laid out, we're going to be creating a lot of extra work for ourselves. And I also would just recommend that we look at few key priorities rather than a whole laundry list of stuff, because that never works out in my opinion, based on my own experience. So I just want to throw all of that out there so everybody can kind of think about that. And I don't think we should feel any pressure today to finalize this list, to make this the sign-off list. We should have the ability to come to digest what was discussed today in this brainstorming activity, come back in a month. People should be looking at reports so that we have a very informed decision-making process. Thank you.
Yeah, those are all good points. And, hopefully you are informed by some of the reports you've received over the last year. This is a public board and you exist for the public also. So you want to be continuing to set goals throughout the year. If there is something that has been brought forward to you, then you should be maybe adjusting your priority areas or, adjusting who's your next speaker, your next site visit, or your next ad hoc, based on what happens throughout the year. But it is nice to identify, let's say, 1 or 2 top areas of interest. We heard from Karen earlier today from the public saying older adult services are so important. We need to work more on that. I don't know that much about your county to know if that's what, that's a priority this board would be interested in. It kind of, with any kind of issue you choose, it's going to be probably, you have to have 1 or 2 individuals that are really invested and interested in that topic. that will do the work to do some research around that and potentially make a recommendation. There may be times that you will choose a priority area that really just means you're gonna have more speakers on your agendas throughout the year, or at least one or two, in that area that are identified, or panels of speakers. In order to help inform you more about that, you might, so we went through all those different tools that you could be using. So it's not like you're gonna change the work of the board just by setting a couple of areas of real strong interest. Anybody have a strong interest? Michael?
Surprise, surprise, but justice involved folks, so both adults and children. And when I say justice involved, although it can include both hospitalizations or this is Vermont, but now I'm thinking about those involved with the juvenile delinquency and criminal justice systems.
And while she's writing that, I think the idea really is to try and identify 1 to 3 goals for the year where we really can dig deeper. And that's what you're suggesting, that might be one of the issues, areas. We can then look into it eventually and say, well, this is already being handled or whatever, or how does this fit in for us? But I think we want to be able to say, these are the issues that we're most interested in looking at this year at this point, and get the majority of the committee or the board, I'm sorry, to say, yes, this is what I want to do too. It doesn't mean we're gonna throw away anything. And I think everything's gonna be up there and we can prioritize it as we want and do what we want with it, but just to get a sense of where we are as a board, so that when we move forward, we are really targeting these issues so that we do have something definitive, hopefully to come back and say, this is what we think we want to recommend. And we can't do that if we don't prioritize and dig deep.
Okay. I agree with Michael, and that's a good one. So I was thinking that we might want to have a goal or priority, in the spirit of integration and unity with the changes that are happening with Prop 1, maybe have something that's called, or we can call it whatever we want, community health promotion, or something to that effect. I believe, Teresa, you called it behavioral health wellness. I was just using this as a term. That would include substance use and mental health and its integration, as you know, because like Dr. Jennering explained earlier, that it's important and it's all in one now. It's not separated any longer. And I would also like to include in that veterans too. I don't know why exactly which names were here, but I know that the substance use is prominent in a lot of populations, and not only veterans, but certainly a lot of populations, and so, and it often has very big effects on people's mental health. So.
Jeff?
Yeah, I was gonna say, going along with what Dr. Dennering described in the restructure of the department, again, using the word integration, but integration of services countywide, west to east, east to west, make sure it's countywide, and making sure that we're, something you had said, Teresa, something about integrating with the schools and integrating with the county office of education, the various school districts and county office. As a former superintendent, we rely heavily on BCBH. We have a lot of issues going on in our schools. It doesn't matter what district, it's happening everywhere. The wellness centers have been a great thing that has come to our schools, but as great as they are, they're not the end all do all. We need continued integration of services with BCBH in our school districts and which include the county office of education and school development, which are schools for students with special needs and even greater needs than that, like more comprehensive mental health needs.
I was wondering, child abuse or neglect would go under this category and taking that more serious.
You say child abuse and neglect.
Just before, hold on, Jeff, do you mind if I also put on here CBOs, community-based organizations that do this? Okay.
Yeah, because that was in my head, I just didn't verbalize it.
Okay, all right, then.
Jennifer?
Thank you. In line with the Carol Sheldon's public comment today, in the advocacy work that I do, I've had several phone calls from people with autism and their families really struggling with the ping ponging that goes on between tri-counties and VCBH on whose job it is. Is it ours? Is it theirs? And while they're trying to figure that out, you have a client languishing, and you know that population is very severe in a lot of cases. And sometimes, you know, I feel like we need to come up with better collaboration between the two departments to get this population the help they need.
Okay. Liz?
Yeah, so, Karen beat me to the
And I'm
punch.
gonna just stop you. I want to make sure, you said regional centers and she's putting down autism. Is it anybody with a developmental or intellectual disability that's being treated through the regional centers and has a behavioral health issue? Is that like a broader scope?
Well, I'm thinking about some of the situations that I've dealt with as an advocate. You're talking about somebody with a dual diagnosis with autism and serious mental illness. And that seems to be a bottleneck, trying to figure out which department is supposed to own that client and provide the services, but I'd like to see more of a collaboration and more first door entry, like how we get in the outpatient clinics, you know, care within 4 hours or 2 hours, whatever it is. I mean, I'd like to see a more serious approach to this population. Thank you.
Real quick, Jennifer, you understand that Tri-Counties, works with families with both, people dealing with, experiencing autism as well as developmental disability.
I do know that.
Okay, so I think that's where she was going to, is like, because that's also a population I see within justice involved folks as far as developmental disability and, mental health or behavioral health issues.
Well, I think if it's all on the list, we could kind of look at how to, you know, bring them all together. But I'm speaking of the more serious population with autism and serious mental illness combined. Does that make sense?
Yes, it's your priority. I just wanted to make sure we were clear.
Can you, Diane, can you add under any of these actually, but under, the integration mental health center, can you put dual diagnosis? Because, you know, it used to be a co-occurring or dual diagnosis. What is it called? Loretta, do you call it either of those anymore? Or is there such a thing? I mean, we know there's a thing, but I mean, what is it labeled?
Depends on where you live, but we use co-occurring behavioral health condition.
Oh, okay, right. All right, so thank you, because we're finding this in a lot of these areas, I think. Thank you.
Matt?
Thanks, Cheryl. I kind of want to follow up on Jeff's priority and maybe make it a little more holistic and just youth wellness. You know, when I say youth, I mean anywhere from prenatal to 5 to grade school to high school. And it's what we're doing. I've seen the impacts of the pandemic, which are drastic and are probably ongoing for several years. Is what, you know, the county approach to youth wellness.
Supervisor, would you add, or would you consider adding MT?
Yeah.
18 to 25?
Yeah.
Okay, so youth wellness and TAG.
Yeah.
Liz?
Yeah, so Karen beat me to the punch. On my list of recommendations is to look at the quality of services for the older adult community, VCBH, older adult clients and non-clients. We have a severe grain of the population. It's the largest group that's now going to be entering into, you know, advanced ages and needing higher levels of care. So I wanted to look at, the feasibility of an adult residential facility, which is like a 45-bed facility for older adults in this county. We don't have them. They're having to be shipped out of county for placement. We want them to be able to age home here, close to family members with dignity. And we want to really take a look at that. I don't know, this is like, you know, best possible scenario, but if it's not a 45-bed, we can look at smaller, but let's start with 45-bed and see what opportunities are out there. And then the other thing is,
Hold on a second, I just wanna make sure we get this down right, so a residential care facility for the elderly is RCFE.
yeah,
And it's really a specific, it's not, yeah, I just wanna make sure we get it
Right.
clear on the list.
right, so I really want to take a look at that. And then the other is just how we can increase beds overall in this county. It's one of the #1 things we have. If people get ill, there's no place for them to go. That's, I mean, it's, a lot of these things are terrific. I want to take a look at them, but at the end of the day, we want our people to be able to be taken care of here in county. Because family members are having to travel long distances to offer support. Case managers are having to travel long distances. We're paying for beds at other facilities, you know, Silmar and so on to keep beds open because we don't have them here in our county. So I'd like to be able to bring more people back home and build, you know, places for them to live. So affordable housing and things that are geared for adults, but also older adults.
When you say beds, do you mean both, infrastructure like behavioral health beds as well as long-term housing?
Yes.
Okay.
Yeah, I do. And I also, I'm sorry, so I'm looking at, so some of that could be for our adult population, we have, you know, the board and care, we have board and cares, okay? Well, we have a board and care for older adults, but it's not enough. We need more, we need more permanent housing for older adults. We also need a higher level of care for them, like, a skilled nursing facility. So we need like SNFs. And so we just need a whole continuum of housing and beds for the aging community with SMI in this county. We don't have it. But Chris?
Yeah, I'm so glad you brought that up, Liz. And then, so two areas that we see a lot, with nonprofit that we run, the Candela Group, is the first part is getting the LPS hold in place. There's only one path to do that in this county, otherwise it's jail. And then, so that's it, broadening that path to be able to get somebody on a hold when they need it and when it's suited, would at least is one area that I think draft really needs to be addressed. And then directly feeding on that is what Liz just mentioned, is where do they go afterwards, which is it's just tough, you know, and so as we've seen in the jail population as well, with the expansion of the TIMU over the past few years, I mean, that just gets bigger and bigger. Essentially, there's correlation there. So I think those two pieces would just, if we can always just go back to those, I think that'd be really good. Thank you.
Genevieve?
Thank you. It's not fully articulated, so please bear with me. But I think if we don't specify something around like language access, how it intersects within the department, I think we're missing an opportunity. I know the department does really well at providing interpreters and making sure things are translated for our Spanish speakers, but I'm curious about like the implementation of these policies, like when someone comes and they're seeking services, like how quickly can we get an interpreter? Are there barriers to getting an interpreter, especially when someone's in crisis? So again, not fully, I'm not maybe landing on what I want to say, but somehow how we can keep language access top of mind. And to Liz's point about there being multiple plans, maybe it's a matter of just pulling from what already exists and just having like, okay, here's like a matrix of what's already, in place and really looking at, okay, well, what's the utilization of that? So like, again, just as an example, I know the department contracts with my organization, my COB for mistake interpretation. I don't oversee that program, but I don't know how often we're getting utilized for that. And so it'll be really good to see that data as well, so that we can truly be responsive to, the population here in Ventura County that has limited English proficient, which is about a third. Thank you.
Nancy, can you hear me? No, you do. That's all it is. Oh. Go ahead, Sullivan, yeah, please. You, Nancy.
Ok, yo estoy de acuerdo en todos, pero mi enfoque va a ser un poquito más, estoy de acuerdo en Genevieve. ¿Qué pasa con nuestra comunidad que no habla el idioma? Y también cuando...
You need to speak into the microphone so we can all hear what
Oh,
she's saying.
sorry.
Hey, that's okay.
I went through at the same time.
Excuse me, I'm so sorry.
It's okay.
She might be taking that, you might be taking at the same time, is that okay?
Well, if she can speak and then if you can speak, pause.
Okay, well,
Thank you. Thank you, Justice.
Estaba diciendo que estoy de acuerdo en Genevieve porque el enfoque de ustedes lo amo y estoy de acuerdo, pero ustedes tienen un poquito más conocimiento en eso. Entonces voy a dejar que ustedes trabajen en eso, pero mi enfoque es la comunidad latina en especial, en el idioma.
Yeah, and I agree with Genevieve. I mean, I completely agree with what you guys work on, but then what I focus more is about the community as well, the Latin community.
Para mí es importante que nuestra comunidad tenga el conocimiento y pueda saber dónde ir o a quién contactar, porque muchas veces nuestra comunidad no tiene ese conocimiento.
What I want to have, what I would like to happen is for a community to know where to go, for them to have that knowledge of where to go once something happens.
Estoy escuchando que quieren entrar a las escuelas, prácticamente estoy en todas las escuelas con la organización que nosotros tenemos y es muy pocas en las que se habla lo que es salud mental. Ahorita hay un poquito más enfoque en las high school.
Yeah, and then the organization that I work for, you guys are talking about like going to schools. I actually go to school and then they're mostly, none of them, they focus more on mental health, only high schools.
Pero me gustaría, y estoy de acuerdo que dice, cuando hay muchos eventos en los que debe de haber un representante que esté hablando de lo que es salud mental en general.
And when there's somebody that's talking about like mental health in general as well, there has to be somebody there.
Me preocupa que no hay mucha información en español. Ahorita todo el papeleo es en inglés, pero gracias que lo pusieron en el email y yo pude entender un poquito más y con los intérpretes, pero me preocupa que muchos papás no saben cómo ayudar a sus hijos, que son en especial los que están pasando por drogas, porque están en la cárcel a muy temprana edad y no saben cómo ayudarlos.
Yeah, and I'm actually glad that, I mean, some of this information that I have is actually in Spanish. And I mean, they switched in Spanish and obviously the interpreters as well. But then we have to understand that some of this communities are actually parents as well. They don't have that information available to them, especially for parents that their kids are going through maybe drugs or alcohol, maybe some of them in jail as well. And they need to have that information as well available to them.
Me encantaría que haya más comunicación, tanto con los distritos como con las diferentes organizaciones, pero que nos enteremos. Desafortunadamente, como les digo, yo estoy en muchas de las escuelas, usted podría decir en todas, y es poca la información que yo escucho sobre temas o entrenamientos de prevención de suicidio o de salud mental.
Yeah, like I said, I mean, I go to a lot of schools, not just one, I go to several of them. And it would be better if there's more like programs about mental health, about suicide prevention, and all the kind of stuff that's gonna help the community.
Y por último, sí, voy a hacer un poquito hincapié de simplemente estamos aquí hace
no mucho hubo un entrenamiento de prevención del suicidio. Para cuando lo mencionaron aquí en la junta, ya no había cupo, se suponía. Gracias a Dios, que alguien me llamó y me dijo que había cupo. Pude llegar tarde, pero lo tomé. Pero creo que es importante que esté más a la comunidad, porque estamos siempre los mismos que estamos aquí, pero no sale de aquí. Necesitamos que salgan de esta comunidad.
Yeah, and then we talk about this here, and then it was actually about like a training that was gonna be happening about mental health. And at the beginning, they said that there was no spot until somebody told me there's actually a spot, and I was able to get there. And I, even though it was late, but like I said, there needs to be more support. That people need to know about this stuff, and like I said, more support.
Just wanna add what Soledad's referencing is the suicide prevention workshop that took place, and at the last, we had a meeting, we were told that there wasn't space. Then someone called her the day of the event, saying that there was space, and so just to add that, she's saying it's really important, and, you know, it's important that we get that information also to the community, because if we're being told there's no space, then, you know, how's the community gonna know?
I just want to really quickly address that. The reason that there was space at the last minute was because there were folks that canceled and they notified the department earlier in the day and they were able to release those tickets. So it wasn't that they were being withheld or not being communicated, they just suddenly became available.
Okay, thank you. Nancy, did you have? No, I did. You did, okay. And I love all these recommendations, they're all necessary and good. And I apologize for being late today, so I may be covering things that you've already talked about. So if so, I apologize, but one of the things I thought about, you know, that the Mental Health Services Act had covered so many broad things, and now it's gonna be so changed. I wish that we could have some of us look at the changes so that we could, and the department is trying to help us understand it all the time, and it's complex and it's kind of a moving target, so it's about the time you think you have it, you don't. And so I thought, well, maybe we really do need to look at the money, money, services, what can get done. And we can have the best goals, but no money, and that's just a goal, and it doesn't help to get things changed. I just would like to know what's changing, what Mental Health Services Act doesn't cover and what it's gonna cover, because it's pretty different. And we have a lot of things in our county that are currently being funded with Mental Health Services Act money. And that hasn't changed yet, I don't believe, but it's going to. So, and I know that there's serious, very serious work going on trying to make sure that things go forward in the best way possible. But I think maybe looking at the money is important.
Yep.
Yeah, Jennifer? Thank you again.
So first is a comment, then is another topic, but I think what I keep hearing is a common thing is beds and housing, beds and housing. I know it's all being worked on, and I'm gonna ask for something when we do board member comments, but in regards to this, I'd like to look at the response time on the crisis team. Again, in advocacy, we get these calls, the crisis team can take 6 hours sometimes, or they don't show up at all. Then you have the CIT team, if the CIT team goes out, might be somebody, I think they're all CIT now, right? So you get a team of sheriffs out there, police, and anything can happen during that time. You know, an arrest can happen, but the response time from the crisis team, I think, could be worked on, and a better collaboration between them and the public safety. And I know that the crisis team doesn't transport either, so that's something that we can look at. Maybe getting transportation vans, police escort, or something that can identify, that can help these clients or not get arrested, something that's a little more collaborative. But response time is a big deal.
Okay. Wow, I just have to say, I'm gonna give you a chance. I just have to say, I came into this meeting with Teresa and I said, well, I hope we get some ideas. I know I Boy, was I naive. She said, I think so. Okay, good. And they're all good.
I know some of this has been mentioned a little bit already, but I'd say one of the things that I was a little surprised about coming into the board is public comments. I feel like we're not engaging the public probably like we should be, and I know schools were brought up. We get things here to probably say, we need to include our military bases, our churches, our nonprofits. I was a little shocked about that, and I think that we need to work on that engagement. And then something from a law enforcement perspective, one thing that my unit in particular struggles with is we have a lot of incarcerated people that are looking for services when they're released, and we just don't have those services available when they're discharged. So I'd like to look into that a little bit too.
Thank you. Also, Janice?
I just want to make sure when Diana writes this, that she's, also, could you just put veterans, Diane, too? You mentioned the bases, what else did you mention?
Churches, nonprofits, schools,
Nonprofits and.
maybe large companies.
Okay, I just still don't see the word veterans anywhere.
It's coming.
Okay. Okay. Someone have James in the absence, sorry, okay.
Okay, now, anything else, and remember, this is just brainstorming, anything you want to say is fine, it may or may not be possible, it may be, you know, we don't care, we just want to see everything up there.
Yeah, if it's okay, then I want to clarify in this last one, because you led with, we need more public comment, so were you really focused on the meetings of the board when you made that comment, or were you also looking at the whole community planning process of the department?
I think a little bit of both.
So when I wrote engage public more, is that close or is that not what you're saying?
That's good.
Yeah.
That's good. Yeah, I wanted to just mention there, one of the counties developed a tool. You know, they create flyers, they do a lot just for their meetings themselves, and they did create a ad hoc committee to get it started, so they could really do more in order to, you know, kind of advertise and make sure people were aware that there was a board for behavioral health.
So I just quickly want to comment to make sure that I understand what you're saying. I think, and if I don't mean to put words in your mouth. When someone comes from the community and makes a public comment, we don't comment or respond to that comment in real time during the meetings. What I think we're lacking is that we never know what happens to that comment. There's no follow-up. We don't know if there was a sit-down meeting with the senior leadership of the department, if they circled back with any of us. So there should be a process put into place where we follow up with all these individuals that are coming out, the stakeholders that are coming out to inform us and to bring these issues to our attention. That's where I think we're lacking. I think it gets frustrating for people who do come and they want to have an interaction, but we couldn't do that and we would never get through our meetings. So I want to make that distinction.
Okay. Chris.
Sorry, I have one more, but this totally reminded me of it. It was, I believe it's, either San Mateo or Contra Costa up north. They have a entire facet or carve out of their county services, behavioral health, that's for the families to be able to have family engagement and family, you know, integration with services and all that planning. That's something that we could look at as well to really bolster that area. I think that'd be,
You're gonna have to give me some work around that.
family,
Are you looking for funding to create space for those families to work together?
it's a particular subset of the behavioral health department, so it'd be as if BCH, the county, had a separate team that just facilitated communication between family members. So maybe family.
Focus on the family.
Yeah, exactly.
Okay. Anything else before we go forward the next step? And this is something you can't think of it and come forward at this point. Okay, Matt.
I just wanna, I know Diane's getting things thrown at her, but.
Oh, she's got it.
What Sergeant Pusey said earlier about, inmates in our system being released, to making sure that there's coordinated services upon release. I think that's something that I understand today.
Right. Ask like everybody why they work it out. Okay, just as a reminder, we're gonna try to prioritize a little bit this, I think, right? Yeah, and those are stickers, we're gonna all go up and sticker, but, please keep it. Please, well, we could have 3 goals, and we have this thing, we have between 1 and 3 goals. But please keep in mind, some of these are gonna go together, obviously, some of these could be put into the same bucket and we can work on them. But the thing I wanna emphasize first is, you're making a commitment to work on one of these. Because as we know, the way our committee structure hasn't really been all that efficient recently, and it hasn't been well attended, et cetera. So what I want you to realize is the idea of this is we're gonna narrow things down so we can really dig into some of these issues. But we have to have people who do it. So please keep that in mind when you're voting. Are you really willing to work on number 1, or whatever you put as your priority? Is that something you are gonna commit sometime to?
Just correcting exactly.
You're voting already.
No.
All right, so, what I want to do is, actually, maybe we might want to stick this up on the wall, it might be easier.
Yeah,
for
I
people
don't
to
think
vote.
people could see it, but.
Yeah.
I think so.
We're gonna see who's got good knees and who doesn't.
I'll stick it up, Diane, stick it up behind you on that flat wall.
Okay.
Everything else needs to have something in front of it.
And, I'd like to invite the members of the board to vote first. And then I have some stickers for the public, if they want to come to me, I'll give you, I have red stickers for you. And the stickers are they're marked 1, 2, 3. So put your top priority as 1, 2nd, and then 3rd.
Okay, as soon as they are on the wall, it's up to everybody to have their stickers and give a vote.
And do the
remember-
numbers actually mean priority 1, 2, or 3, or
Yeah,
just
yes.
random?
Yes.
Oh, okay.
And there are refreshments in the back if you're falling asleep, getting tired.
Yeah, they're all important.
Right.
Something on like one of those picture hard and say, yeah, crap.
was gonna say, she's doing great, she's watching the grandbabies today. Yeah, she was, yeah. She was saying
Everyone needs to know. Oh, there's a lot.
I know. Oh, wow.
Brother Walls, the hospital.
She's been on this.
Yeah. Yeah.
Nice to see you. I'm waiting for you anxiously. Finally.
Yeah.
Great.
We had a chance to put their colored dots on. Anybody has it? Yeah, it wants to. I love that you're all talking, I really do. But it's of time. We do have a couple more agenda items, so I just want to sort of get us back together. But I just want to tell you how much I appreciate everybody being here today. We have almost a full house. The 3 or 4 people are missing for very good reasons. They just still want to be part of us and they'll be coming back. I've talked to pretty much everybody online or on the phone. Anyway, so I appreciate all your participation. I think everybody was hungry for this kind of a meeting, so we could really talk about what the issues are and what we see. As you look at those, three sheets, you will see there are certain groupings. Well, obviously, there's things we can group together. We will do that. I'm gonna talk about that in a minute, but there are certain things that really do have more dots, which is kind of was the idea here. So I think we're gonna easily come up with kind of groupings and several of those feel really fit together, I think, rather well, so that we would really incorporate quite a few and get them into something that's more manageable. So because we really can't do that probably today, I'm going to take the responsibility with a couple of other people probably to really put the groupings together. You can, and we'll also take pictures, a couple of people are taking pictures, so that if you don't agree with the way they're grouped, that's fine. I know you will. Which I'm so happy about, really. So, and then we'll bring them back. We'll send it out before our next meeting, and then bring it back at our next meeting to really hopefully come up with our goals. I think this will. It looks difficult right now, but I think when we really look at it, it won't be so difficult. I think it'll make more sense. And remember that all of you are going to be expected to work on one of these, one or two or three goals. So we will group them, and Teresa's volunteered to help with that, which is really nice. We really appreciate that, because she's done this before, yeah, so this is really helpful, and I'm gonna ask Teresa if she has a few more comments, but I just want to say thank you so much. This was terrific.
You all, and it's always so interesting for me to be listening to what people really care about. So this was the perfect meeting for me to come to as well. On the state level, we listen to counties like this, and we decide on our own priority areas as well for advocacy. So I'm gonna stay in conversation with Cheryl about your list here and, talk about ways that, you can incorporate into your agendas, items, or, use some of the tools that we talked about. And just wanted to leave by saying again, thank you so much for working with this board, either as a member, or staff, or the public. Really appreciate it.
Great, thank you, thank you. We'll probably be calling you again. Okay, moving along, is there any final comment on this before we move to the next agenda item? Okay, moving along, we have committee reports. That's where we are next. Janice, here's committees.
Hi, I have a report from July. I was out on a bereavement leave the last 2 months, so I just wanted to give the report. And this, we had a presentation, the Prevention Committee had a presentation from Vicki Gonzalez, who's a director in public health of tobacco and prevention. And her topic was primarily about vaping. And she said that there's been a steady increase in vaping by teens and adults with both cannabis and tobacco in recent years. In high school, vaping has increased dramatically, particularly for 12th graders nationwide, and then again into young adulthood, which is the teen population. Vape pens come in all sizes and shapes, including some looking like highlighters and black Sharpie pens, so teachers cannot detect them. Some of the flavors include fruit medley, creme brulee, Virginia tobacco. Mint flavored tobacco has been outlawed in California, but Arizona and other states remain sellers of the mint flavored tobacco. What many do not realize is that there are cancer-causing chemicals in the vapor. Formaldehyde, a cancer-causing substance, may form whenever the e-liquid overheats or when there's not enough, or when not enough liquid is reaching the heating element. This is known as a dry puff. Nicotine in e-cigarettes can be addictive and can harm brain development with exposure in teens and young developing brains. Cannabis may have long-lasting effects in the still developing teen brain. It can cause impaired reaction time and coordination, and in some can cause increased risk of mental health issues, including depression, anxiety, or worse. Long-term effects of vaping inhalation are not all completely known, but we do know that there are also chemicals such as chromium, nickel, lead, and zinc in some vaping products, and we are aware that none of these chemicals are good for a person's health or lungs. Prevention in this area includes education, particularly for parents of young teens and the teens themselves, denormalizing and deglamorizing, sharing research, having adults model good health behavior themselves, vaping enforcement within municipal code compliances, business standards, advertising, and promotion. Also, strong enforcement of state and local policies on products and sales, and posted enforcement of local policies and the expanding of local action to deter retail and social access for youth. So that concludes the report for the last prevention committee in July. Thank you.
Thank you. Okay, moving to board member comments. Yeah, Chief. Sorry.
I'm just going up real fast.
Oh, okay, go up real fast.
Sorry.
So I wanted to ask Dr. Jennering, I know, so we have the MHRC we're working on, we're waiting for the East County CSU. I was wondering if just part of your director's report every month, you could just come back to us with a short, brief update on where we are at with the facilities that are currently been approved and are working on.
Yes.
Yes, thank you. Is it just the two? Is it the East County CSU and the MHRC? Is there any other facilities that are being worked on?
So, I mean, so we've talked about, there are multiple different avenues, right? So we're talking, there's Prop 1 bond BHAB application that we're still mulling through. We had CO's capital projects come and do a presentation on that in September, August. We're still, I know. We're still working on those applications and those are due in December. So by our next BHAB, we may be closer to knowing exactly where we're going as far as with those applications. And then there are other things in the works as well, right? So we can talk about a more broad infrastructure update probably in December, because at that point, we will be done with the BHAB applications. We'll kind of know exactly where we're going infrastructure wise. A lot of what we've been talking about in the last several months has really been the community engagement piece, hearing what we know the needs from our perspective in the department, hearing from you all in the BHAB, hearing from the community, and then putting together what we're able to do based on what the application parameters are, and then fiscally, as we talked about during the last meeting, what the county is actually able to support. So in that next meeting, we can have a more comprehensive update. So December.
Thank you. And I'm thinking, like, I remember I remember the update with the CSU being, they have a facility identified. I'm not sure where that's at. So I think, at least for me, and I'm sure some other members as well, just having a monthly update on, we're waiting for this for the CSU, we're here with the MHRC. You know, just having a brief update is helpful to know what's going on behind the curtain.
Sure, I mean, some of that is nuance, right? And things change rapidly. And again, we're talking actual brick and mortar construction, which is outside of the realm of the department, but we will provide updates as we're able to.
Just real quick, I'm saying, I think that's really important, even if it is, we're waiting for this person or we're waiting for that institution or whatever, but just having a step-by-step and knowing, because I think sometimes, at least for me, when we can't peek behind the curtain, we don't know what's happening. And so then some of us, sometimes me, I assume nothing's happening and then I get irritated. I'm just kidding. But yeah, so just having that update, it would be great.
Sure, no problem, thanks.
Sure, Nancy. Oh, I just wondered if you could speak to the fact that we had a public comment from the director of the Casa Pacifica. You know, voicing concerns about the site, one of their sites. Was that, and they were gonna go with you and have a big meeting, and I drove by that place and I looked myself and I thought, I don't know, seems like that could work, but I'm wondering if you, has that been approved as an agreeable site?
So, yeah, we talked about it, I think you were out in that meeting, but we did follow up in the next meeting, I did provide an update that we did meet with Shauna and her team, myself, some folks from CEO, Capital Projects Division. And we talked about the concerns, very valid as far as, you know, the lines and the safety. But we've come to an agreement as far as, you know, having constant communication throughout the process, you know, the project is going to happen. And how we can work together to make it happen and, you know, try to address the safety needs and concerns for everybody.
Thank you. Janice?
I wanted to give a brief update, as the chair of the bylaws committee. I wanted to, first of all, thank the bylaws work group. I wanted to, thank the members of the work group, and that's, Cheryl, Diane, Liz, Michael, and CJ for taking 2 hours, more than 2 hours out of every month to meet. And I want to give you a status update. We have finished our edits, and the bylaws are now with Dr. Jennering and will also be reviewed by county council. No, you don't know, they're not?
No, she knows they're coming, they're coming.
Oh, they're not with her yet. Okay, well, okay. Anyway, within minutes, hours, Michael.
Already sent it to you.
No, it's overrun.
Okay, see, minutes. Dr. Jennering will have them, and then, after, Dr. Jennering and county council reviews, they will come back to our board. And at that time, we will take a look at them and hear your comments, and, I wanted to thank Teresa, also, no, sorry, wait. Not Teresa, Teresa. I wouldn't call you that, Dr. Joe, in public, but, anyway, for all of the work that you did, because a lot of the changes and edits that we did in the bylaws, were, extrapolated directly from, the California, behavioral health, commissions and boards and commissions, so, we'll see what you all have to say, and we worked really hard, and we'll take a look now, just to recap, the bylaws will be going to, once they're approved, will be gone by yourselves, will be going to the board of supervisors. We will also be,
Love them.
yes, you will love them, and then we will also be drafting another document that does not need to be approved by the board of supervisors, which will be called something to the effect of a policy and procedurals manual. And that will be just primarily our internal policy and procedures, and again, you'll all have time, you'll all be able to weigh in with that manual as well. So that's it for now, and I just wanted to update everyone. Thank you.
Any other board comments? Okay, and I just wanna say, I neglected to mention that we did do two public comments came in by email. And they're good comments, as they always are. They will be included and sent out to everybody here in the next round of minutes, and one of them is very specific, which would be Carol Shelton had some very specific input on HCA, the needs assessment, which we'll get directly to Dr. Cho. So she'll have that. Thank you. Okay. Old business, we have data notebook on there, and that actually has gone to the bylaws committee. Yes, so but Diane can maybe say what we're thinking about that. I don't think there needs to be action here because it'll actually be in the bylaws, the recommendation, but as long as it's on here, I was supposed to. Why don't you just go ahead?
I suggested that the data notebook be done by the first chair with assistance from the second vice chair.
And that's going to be written in the bylaws so that we always know who is gonna be doing the down in notebook. It's two people. So they can help each other get it done, working with the department and get it in on time. So as long as the bylaws get approved, that will be permanent, but for this year, James and I will be doing the down in notebook as their first vice chair and second vice chair.
That's very generous of them. Yes, we do appreciate it. New business, site visit update. You have anything there?
No, you're not.
Okay, not yet. We're gonna, hopefully the site visits will, for when the family salary. And your phone is off. No, I'm hearing you because it's not working.
Sorry, that we're not there.
Sorry.
Oh, this is home.
Oh, I see. No, yeah, no. Okay, okay, now it is. Okay, thank you.
Jackie?
Yeah, Jackie, right. These are all, by the way, these are old and on the, they're on the list to be updated. Okay, so the site visits, as we said before, hopefully we will do at least 2 this year. We're gonna correlate them with our goals. So just so people know that's not, we're not forgetting a presentation request, anything, recognition of boards, again. If anybody has anything, please send it to myself or Jackie or both. Okay, contracts. Anything on any of the contracts? There weren't very many, so assuming we read that thoroughly. Any feedback on the contracts? Anything in your packet? No? Okay. Okay, any other public comments? This is the time when we do make sure we did get all the public comments from people who are here or online. Okay, okay, that looks like, we are ready to adjourn, and we did well. We said we'd schedule 4 for you two, getting out at 3:40. I just wanted to be noted, so you all did very, very well. Thank you all for participating. It was great participation and enthusiasm. Thank you.